I told you that part one went by pretty quick. Part two may take a little bit longer. We're going to go a little bit more in depth into some of the things that we talked about involving triage, setting up treatment areas, and we're going to go a little bit into incident command too. And then I've got some forms and stuff to kind of give you an idea how to organize this when you have to deploy it. Now, how many in here are taking the incident command course online? Some of you have. The FEMA thing, ICS 100, 200. You can, there's ICS 100, there's ICS 200, there's 300 and 400, which are administrative, executive level courses that are in-house that FEMA and Adam offer. And then you've got 700 and 800. I would encourage everybody who hasn't taken those to get online and do that, because that is the accepted standard across the United States when it comes to dealing with a large-scale emergency. And so, real quick, we're going to kind of just go real quick through the incident command process and the way that it works. We're not going to get real in-depth into it, but there's two different kinds. You've got the actual incident command system, and then you've got unified command. And what that is you'll have up here, you'll have an incident commander. And then down here, you'll have little tiers that come off. And you have the ops section, then you'll have, like say, finance and admin. You'll have logistics. And then over here, you may have whatever fits your needs may be over here. Now, under the ops section is where we guys are going to focus as CERT, because you guys are the boots on the ground. You're the ones that are out there doing the job working. Over here in logistics, these are the folks that need to make sure you get what you need to do the job. So if you get assigned as the logistics section chief on an incident, you're the one that's going to be talking to these people up here, saying, what do you need me to get you in here to do the job? And so that person will facilitate that. And then once it gets there, it'll be moved over and dispersed out to operations so that they can use what you have brought in. Finance and admin, you're probably going to obviously need somebody as an administrator or as an administrative section chief who can document and keep track of everything that's going on. At the same time, finance being, if logistics is out here buying up thousands of dollars worth of stuff to use on this scene, finance is going to have to make sure those bills get paid and or put the brakes on and say, hey, we can't afford this. And so you see how all of these groups work together. And all of them answer to an incident commander. Now, in a unified command, it's a little bit different. All the lower stuff is going to stay the same, but instead, you're going to have an incident commander, say, from the police department. You'll have one from the fire department, the fire chief. You may have the director of public works over here. And this team of leaders will be the ones that are going to make the decisions on scene. And so sometimes unified command isn't always the best way to go. And in this environment, that's probably what we're going to wind up with, because obviously you're going to have the director of police and public safety is going to be on scene, or one of his designated representatives. You're going to have the president of the college. You may have the head of physical plant there, and they're all going to be together saying, okay, here's what needs to be done. In a large incident, whenever you're dealing with all the city directors and stuff like that, it can be a nightmare of egos. And sometimes some people, they don't like to yield to somebody else. But it does give fresh perspective whenever you've got other people up there making decisions and a different outlook on the same thing. So a little bit of how incident command works. Now, when you get down here to ops, you'll have an ops section chief, and then you'll have a team leader. This is where we're going to fit into this. The team leader, whoever it is on scene for CERT, is going to be the one that's going to be directing the teams to do stuff. Now, I'll go ahead and start passing these out. A team leader, yeah, that'd be great. The team leader is going to have to be responsible for these assignment tracking logs. They're going to need to be tracking what the team is doing, what they've been assigned to, and what they're actually doing, so that whenever an incident commander says, "Where's your CERT team? What are they doing?" Okay, CERT team 1 is doing building damage assessment. CERT team 2 has established a treatment team. They can give real-time factual update. Not only that, in a large scale, if someone gets lost, we know who they were with, where they were assigned, and what they were doing whenever we lost contact with them. So, the assignment tracking log will help with that. Now, I said before, you'll have a logistics person, someone who is going to be responsible for everything that's coming through. An equipment inventory. One of the things that a logistics person is going to need to know is what they have at their disposal, what's in their inventory. It may mean that this person, as equipment and supplies are arriving, they document this in their inventory on scene, so that when someone says, "Hey, do we have this?" they can look down and say, "Yes, I have this much of this particular thing that we can use."
On our campus, the logistics person would probably be somebody from the police department.
Not necessarily. Once you get your team developed, it'll be incumbent upon you to take notice of what you have. And it may be something as simple as you all have a CERT bag. You'll know that you have X amount of helmets, you have X amount of sets of gloves, and whatever. That way, in case somebody can't use their bag, it's just sitting over here on the side, you know you've got that in reserve. I made reference, maybe in the evening class, if somebody brings a pallet of water and drops it off, you need to log that in the inventory as we have this equipment, this available to us. One of the things that the logistics officer will have to be very mindful of is in a large-scale disaster, you see all these people that jump in and want to help, they want to donate stuff, they want to give to the cause. Especially like during large tornadoes, you see people just showing up with truckloads of stuff to give. Be very careful of that. If you're at this gate and people are bringing stuff in, make sure that you get some form of a receipt and know that it is free. There was an issue, not the Mayflower Bologna tornadoes, but one before, where this guy brings a dozer and a bunch of excavation equipment that from his company that he owns, donates his time, effort. Everybody thought he was donating his time and effort, and then he sends a bill to the county for the services rendered. So, understand, somebody drops a pallet of water off, make sure it's free. Because if they're going to charge you for it, no, there's plenty of other people that will give us water. And that logistics person needs to coordinate with the finance person to make sure that this stuff is free. So don't just let people start dropping stuff off equipment-wise. Okay, these are the extras for the equipment inventory. All right. Now, once on scene, there's going to have to be somebody, again, the administrative section chief or the administrative team leader is going to need to start checking people in on a roster. A lot of forms, I know. These aren't even half of it. That way, again, you know who's on scene and who is not. Who's authorized to be there, who is not. And not only that, it keeps up with work rotation. If it's going to be an extended event where you may have to work in shifts, these people can know, okay, they've been out here working for 12 and a half hours, they need some downtime. And you start trying to rotate fresh personnel through. And then when they leave, they sign out of the incident. That way we know that they're no longer here, but they are accounted for. They're not stuck in the rubble somewhere. All right, I'm going to save that one for last. So, So that's a little bit of an overview of that. The second level of disaster medical operations, we'll talk about treatment team or treatment area setup, and we're also going to talk a little bit more about some of the other injuries and how to treat them. So a little bit of a review from level 1, the 3 killers: airway obstruction, excessive bleeding, and shock. We talked about the CERT size up, the things you're going to want to do to size up this scene and to continuously assess what's going on to see if things are changing for the worse or better. The objectives: take appropriate sanitation measures to protect public health, perform head-to-toe patient assessments, establish a treatment area, apply splints to suspected fractures and sprains, and employ basic treatments for other injuries. The topics: health considerations. Anytime you're dealing with a lot of people in a space that are injured or sick, you may have a public health emergency. The Department of Health, they have people that respond to large killings just to monitor things like this. Functions of disaster medical operations: establishing the treatment areas. We're going to talk about the logistics of that and how to do it. Conducting a head-to-toe assessment. Now, she gave you a little card a while ago, and we'll get more into that, talking about whenever you get touchy-feely with somebody, what you're looking for. Treating burns, wound care, fractures and sprains, nasal injuries. A nasal injury, y'all think that could be serious? Given circumstances, it can be very serious. Treating cold-related injuries, heat-related injuries. Folks, we don't get to pick when a disaster happens. It may be in the dead of summer, it may be in the dead of winter. And although they may not be experiencing frostbite, we have to constantly monitor that if they're sitting outside for an extended period of time or they're displaced. So that's something we've got to be mindful for. And then bites and stings. Maintaining proper hygiene, we have to do that every day. And not only that, it helps keep our immune system good, because when you start dealing with sick and nasty people, you don't want to get sick from their junk. Maintaining proper sanitation, purifying water if necessary, and preventing that spread of disease. So how do we maintain that? We wash our hands frequently, or we use alcohol-based hand sanitizer. When you're dealing with multiple patients, obviously you're not going to carry around a box of gloves and put on a fresh pair of gloves for every person you encounter. So how do you get around that? Get some of the alcohol-based hand sanitizer, and if you've got blood or whatever, put that stuff on there, kill the germs. It may not look pretty, but it'll be sanitary. Also, if you have the ability in a treatment area where you are dealing with multiple people treating, go ahead and get fresh water, put bleach in it, and just put your hands in it with your gloves on. Get that stuff off, and then move to your next patient that you're working with if there's a lot of blood and junk. Always, like we talked about before, wear non-latex exam gloves. We're going to treat everybody as if they have a latex allergy. Wear your N95 mask, and the N95 mask will come in most of your CERT bags. They're the cheap looking dust masks. Has a little square on the front of it. All the ambulances in Arkansas are required to carry them, because that will actually prevent you, if you're in an environment with TB, it'll keep you from contracting it. That little mask can go a long way. But it's got to be an N95 mask. Keeping dressing sterile. It's going to be very hard to do in an environment where there's going to be so much dirt. There's going to be a lot of blood, a lot of fluids, a lot of yucky stuff. But try to do the best you can to keep it as sterile as possible. And then you have to avoid that contact with other body fluids. And then the acronym: if it's warm and it's wet and it's not yours, don't touch it.
Some warm, wet stuff that is ours, you shouldn't touch it.
Exactly. When you have bandages, gauze, a lot of bloody soaked rags, things like that. Go ahead and start you a bio-waste bag, a medical waste bag. If it is a finger or an arm or a leg, we'll talk about amputations in a minute. But if it's something like that, you may want a clear bag to save it, because they're going to want you to save it. Okay? And tie them off, and make sure you mark them as medical waste, that way they can be incinerated and disposed of properly. We'll talk about bites and stings, we'll talk about anaphylactic shock, things like that, and how to dispose of a sharp. If someone is a diabetic and they give themselves their medication, they may have a needle that needs to be disposed of. You just don't want to throw it in a trash bag with everything else. They make little sharps boxes, and we have some that you can dispose of. An EpiPen, some of them now, most of them have the retractable needle, some may not. And then bury human waste, fecal matter, things like that. If you have to, you can bury that stuff and it'll biodegrade. Sanitizing water. We may not have an infinite supply of water readily available depending on the conditions. If infrastructure's down, water lines are busted, we don't have access to fresh running water, it may be 24 to 48 hours before the National Guard can bring a water buffalo out and set it up. Or if you don't have running water where you're particularly at, but the fire department can facilitate a dump tank. They can put a lot of fire departments have a big folding tank that they can use to draft out of to put out house fires. Have them drop that tank and dump about 5,000 gallons of water into it, and then start using that to treat, using it, rationing it out, and purify that water. You can obviously boil it. That's probably the standard method everybody uses whenever they have a boil order for their home. They boil the water. They make water purification tablets, drop a couple in there, let it sit for a little bit, it purifies the water. Military uses these pretty frequently. And then if you don't have any of that, under extreme circumstances, 8 small drops of bleach to a gallon of water. You can drop that in there, let it sit for 30 minutes, and it will be safe to use to drink if necessary. That's the reason why it's down there at the bottom. You don't want to have to do that if you have access to the other 2. But it does work. So the function of disaster medical operations: triage, treatment, transport, morgue, and supply. You guys are going to be the ones facilitating the first stage of care at a disaster scene. You're going to be setting this up, you're going to be organizing it, so that when EMS gets there, they'll be the ones that are taking care of the transport, the long-range treatment. But you guys are the triage, and you guys are probably going to have to establish if it's bad enough, you'll have to establish a morgue. And you'll have to make sure that you supply what's necessary to do these things. So establishing a medical treatment area. You need to kind of think about, whenever you're having to do this, you stop and you look around and you're assessing the scene. That's one of the things you need to assess for. You need to be able to say, where's the best place for us to set this treatment area up at? And there's kind of some guidelines. Go ahead and pass those. As soon as injured victims are confirmed, and there's a lot of them. If there's just 2 or 3 people, then no, you don't need it. But if it's what is classified as an MCI, mass casualty incident, then you're going to have a treatment area. When you're thinking about what's the best area, think about the safety of you and the people that you're treating. You don't want to, if there's a hazardous materials area or situation which CERT stays off limits of, you don't want to be close enough to it to where if the wind shifted, now you're all victims. Also, the most effective use of your resources. If you've got 6 to 8 people on this campus that are going to need a bed or bed confined for some reason, campus center may not be the best area to establish a treatment area when you've got AHEC over here. And you've got the equipment and the facilities. So you always want to use what's the most effective use of your resources whenever you're determining where you want to do this. Needs to be in a safe area, free of hazardous debris, upwind, uphill, and upstream if possible. If you're in an environment where you do have a running, open area of water, you want to make sure you get the cleanest water possible if you decide to use that water. But if it's downhill from the disaster, there's no telling what's rolling off in there. If you're dealing with a tornado and houses have blown down next to this water source, and there's all kinds of household chemicals and nasty junk going into the water, and you're downstream of it trying to treat people and use that water, it may be containing all kinds of yucky stuff. Accessible by transportation vehicles, and it needs to be big enough where you can expand it if necessary. If all of a sudden we've got our situation rocking on here because of something that's happened community-wide around the area, and we're working and we're doing our thing and we're treating our folks and we're in the groove, and then all of a sudden North Little Rock calls and says, hey, you guys are doing a great job. We've got about 50 more people down the hill that we're fixing to bring to you. Well, your stuff just got bigger. And you got to be able to expand that if you need to. Now, if this thing has to contract, you need to be able to contract too. You have all these patients. Now, you don't have all these patients. You may just have a handful of folks. You need to be able to bring it down to a small area. Help meet the challenge of limited resources. Guys, you got to work on a shoestring budget. You guys don't have the big rolling trucks like some of the first responder agencies do that have all the mobile command, has all this fancy stuff all packaged and ready to roll out. You're going to have to be able to use what you got at your disposal. What you can look at something and make it, it may not have been designed for what you need to use it for, but you can make it work. And we'll talk about when you have to spinal immobilize somebody. Everybody has seen the long, big, pretty orange spine board and the blue spine boards and the nice straps and the head blocks and all that stuff. The same thing can be facilitated by using a door and a pair of shoes and some duct tape. Use the shoes as head blocks, use the door as the board, and then strap them to it with duct tape. So you have to be able to look at what you have. It may mean that you're pulling stuff from a blown down house to use to your advantage to help somebody. Talking about tourniquets the other day. You may not have a nice fancy tourniquet, but if you need to facilitate one, you've got a set of shoestrings or you've got a nice leather belt. It's the same thing. Decentralized medical treatment location. You may wind up having to have more than one. There may be logistical factors that prevent you from having one treatment area. It may mean that you have a whole list of people that's over here in this area, but they're cut off. You can't get an ambulance in there to them. They have to be carried out one at a time. And so you're going to have to establish a treatment area over here, but you may have to have another one up here as people are bringing them out one at a time, waiting on transportation, waiting on an ambulance. You may have to have those too. So, back to unit or section 1, talking about triage. Which one's the worst one, color-wise?
Black.
Black.
Oh, black, worst.
And then the worst that are still alive, red. And then yellow, and then green. So this is what you kind of want it to be like whenever you set one of these things up. Okay? You're going to have actually what's going on, and we'll kind of put this into perspective a little bit. Find my, what do I do with that black marker? Say you have, I don't know what I do with it. Oh well.
I thought you said behind the margin.
I might have. Say, for instance, you have an incident at campus center. Okay? Oh. Awesome.
Do the logistics now.
There you go. Logistics.
Logistics.
You need something, you got it. All right. We're just going to call this the South Area Campus Center, and this is the big parking lot, right? Okay, so you have an incident campus center. And as people are bringing out survivors, right here, we may want to have triage somewhere right in there. Just, oh, back up. Just like right in here. As soon as they're being brought out, they're immediately classified, triaged, and they got a tag on them. Okay? From there, based on what they are, their criteria, we may have a treatment area where the parking spaces are over in here. We may set those treatment areas up right in here somewhere. Now, you notice they've got the morgue out here to the other side. You never, ever, ever want to start piling dead bodies up next to people that are being treated in a treatment area, because that will freak them out in a hurry. Not only that, part of our job is to, whenever we talk about, we want to minimize the impact of the disaster as much as possible for the survivors. You'll see that a little bit more in disaster psychology. But these people have already been through a very traumatic incident. They're hurt, they're injured, they're scared to death, and now they see people that are laying over here dead. It'll start giving them the idea that they will not survive. And the same thing goes to whenever everybody's been through the active shooter class. It's a mindset. You have to have that will to survive. And these people need that, and they need that encouragement during this time. And whenever they see bodies stacked up next to them, they don't feel a lot of hope. So we want to establish our morgue somewhere different. So we might want to wind up over here on that grassy area off to the side of Campus Center, around where the building is, away from there. That may be where we want to put our morgue. Out of sight, out of mind over there. That way people don't see what's going on. Now, whenever ambulances and personnel start arriving, when they pull in down here, all they've got to do is pull right up here and stop, and they have a nice, pretty line of ambulances. And they can pick up the reds, they can pick up the yellows, they can pick up the greens, and then not only that, but you've got scenic right here. The coroner can come right up through here and pick up bodies on the other side without people noticing what's going on over there. So, whenever you you have to set up a treatment area, think about what would be the best way to facilitate this. Assign a treatment team leader to each treatment area. This is the person who is going to be in charge, and they're going to be documenting everything. Again, we talked about the triage tags and we learned how to use them. They need to take that information from that triage tag and they need to put it on this paper. That way they check and they double check. That way we don't lose anybody. We know where everybody is and they're accounted for. Try to get as much identifying information as you can. It may mean that they have zero ID on them, but if all you can get is a middle-aged male with brown hair and has a tattoo on the right arm of this. Try to get as much identifying information as you can. You can list him as a John Doe, but put that identifying information on that paper. That way they can say, okay, yeah, that guy didn't make it. He's over in the morgue. We know the tattoo. So, good description. Clothing. You may document their clothing, what they were wearing. Their injuries. Guy with brown hair, tattoo on his left arm, had a severe laceration to the face on his right side. What you did, you want to always document what you did. We bandaged the laceration, or if you had an amputation, packed the wound, packed the limb, transported it with the body, kind of thing. And then where they went to on that triage tag, it's not going to have that where they've been sent to on that little strip that you keep. You're going to have to put that, whoever's documenting that, when that ambulance gets there, you look at the offender number on that ambulance and say, okay, this ambulance took them, and you just ask them, where's this one going? Because they're going to know ahead of time. And they're going to tell you, and you just mark it down. So a head-to-toe assessment, we're going to back up a little bit to when you're actually treating somebody in the field. Again, this is not something that you're doing during triage. Again, the triage is just a quick once-over looking for the 3 killers, giving them an overall eyeball of, are they going to make it, are they not? What's this look like? Giving them a color and getting them to a treatment area. Whoever's working in the treatment area will really need to go more head-to-toe into an assessment. And the reason being is you may look at them and say, okay, they're a yellow. And when they get to the treatment area, once you do this head-to-toe assessment, you may find something that he doesn't see or wouldn't have even been looking for that makes them a red, and they need to be moved to the different area. So it determines the extent of the injuries, the type of treatment that may be needed, and it helps to document more thoroughly the injuries that they have. So everybody's got the little card, DCAP BTLS. This is an acronym that every EMT, paramedic, first responder use whenever they are doing a head-to-toe trauma assessment on someone. So when you start, and they kind of get this backwards because the later slide shows you where to start and where to work. We're going to go head to toe. But what you want to start feeling for is deformities in the head. If you start feeling around their head and they're unresponsive and they're not breathing or whatever, and then you feel the back of their head and it feels like mush, they got a big old skull fracture and they're probably dead. Okay, so you want to feel for deformities. Contusions, if they've got bruising in a particular area of the body, that may be indicative of, that might tell you what they did. Just like people that are involved in a car accident, whenever you see that chest all bruised up, what did they probably do? They hit the steering wheel. Another thing too, when talking about contusions, you see what they call raccoon eyes. That is a sign of head trauma. It's something to be mindful of. Abrasions, puncture wounds, I mean, anything from debris puncturing them. Could be you were at the wrong place at the wrong time and see a stabbing occur. Big old puncture wound. Burns, tenderness, and when they say tenderness, it may be when you are feeling of this person, actually got your hands on them feeling, and you grab a section and they respond to painful stimulus. Where, I mean, they squint or they wince. You know that that's tender on them. You don't know what's going on there, but you know something's going on there. Lacerations and then swelling. When you're assessing them, and again, they've got these out of order. If there's light damage done, depending on the scene, and you know you're safe, you can assess them in place. You can take that time to go over them. If there's serious structural damage going on, or they are in serious, you can tell they're in serious trouble, move them to the treatment area to do this. Assess and tag everybody, we went over that. And then both verbal and hands-on. The person doing this assessment needs to be vocalizing what they're doing. It may mean that the person can see you, hear you. They're scared, but they don't know what's going on. They may not be able to communicate with you, but you need to tell them, just like we want to always walk up to them where they can see us, tell them who we are, and then ask them. They may be able to nod. They may not be able to speak. So always vocalize what you're doing as you're doing it. And not only that, if for some reason they can talk to you, they are alert or whatever, and you tell them what you're doing, when you get to a certain section of the body they don't want you to touch, they'll tell you. So, and back to that too. As you're doing that, somebody needs to be documenting any injuries that you find. Pay really close attention. If it doesn't feel right, it may not be right. If you're feeling something back in here and it just, that's a big old bone sticking where I don't have a bone there, document that. Look, listen, and feel. You're looking at stuff, when you're listening to them, if they're laying on their back, and every time they take a deep breath in, you hear just this gurgling sound, like they're struggling to breathe, document that. Do what you can, make sure the airway's still open. We don't want to get focused on the big open hole in their stomach that isn't bleeding whenever they can't breathe, because we're so zoned into that. So look, listen, and feel. Check your own hands for bleeding. If they've got a spinal injury and you had to tilt them to feel of their back, and all of a sudden you feel of their back and then you come up with a big old bloody glove, there's something going on back there, obviously. But again, in a disaster environment, how many people may you be dealing with that's bleeding? And we're having to move from one patient to another real quick, and yeah, we may wash our gloves off, but there still may be some blood. Know the difference between, is this fresh or is this old? If you suspect a spinal injury in an unconscious victim, you want to obviously treat it accordingly. If you suspect based on, yeah, they're not moving, they're not talking, they're breathing, but they're unconscious, and you know they fell from a distance of 5 feet, and that don't seem like very high, but you can get hurt pretty bad from a 5-foot fall if you land right. You want to treat it just like you would if they were alive or conscious and alert and oriented. Check for pulse, motor sensation, and all their extremities. When we start talking about splinting here in a minute, we'll talk about that. And then look for medical identification. They may be wearing a pendant or a bracelet. They may be a diabetic. It may mean that, yes, they were involved in this disaster, and it's just luck of the draw that they went into diabetic shock around about that time, and they're not injured, but they just need insulin. And they get that, and they're good to go. So look for those medical ID tags. So order of assessment, when you do this head-to-toe assessment, start at the head. Again, what you're going to want to do is you're going to just put your hands on them and just kind of move your fingers and kind of push and feel. We're not going to rock their head and their neck back and forth and stuff, but you're just going to want to feel lightly. And then look at your gloves, see if there's any blood. Then from there, move down to the neck. Check the neck. That generally is a pretty good time to get a better assessment of what their pulse is whenever you want to check their pulse. From there, move to the shoulders. Check the shoulders, make sure that everything's intact. And then at the same time, you're going to move to the chest. You're going to want to actually push, kind of maybe rock the chest, because the ribs, you'll be able to tell who in here's had a broken rib. Anybody that's had a broken rib knows it hurts to breathe. Okay? You could breathe okay, but it hurt. And it may mean that this person, whenever you start rocking on them ribs, they're going to let you know it in a hurry. If they can, they're going to tell you, because it hurts. Now, it doesn't mean that they're having difficulty breathing because they're, it's those ribs that are broken, and you may be able to feel them. And crepitation. Let me get back to a head thing real quick. I got ahead of myself. When you're dealing with head trauma, how many of you have heard of what's called the Battles sign? When you're looking at someone with a head injury, they'll have a big old dark bruise coming right behind their ears. You'll see it starting to develop. And I mean, it's very pronounced, it's very noticeable. If you see that, or if they've got clearish liquid coming out of their ear, that's a definite sign that they've got a serious head or spinal injury. And that clear liquid that you'll see is cerebral spinal fluid coming out of their ears. So if you see those things, and you see the battles, the raccoon's eyes, then you know you're dealing with a bad head trauma or a spinal injury. So, from the chest, work down the arms. Are we going to be really concerned about the arm? Now, from here down, I don't care. Now, if it's up here in the brachial artery area, from pretty much the shoulder down to here, yeah, I may worry about that. But from here down, people live every day without an arm. I'm not concerned about it. Now, if they've slit their wrist, you're going to know that pretty quick. That'll probably be one of the first things you see. From the abdomen, what you're going to want to do is you're going to want to palpate all 4 quadrants of the abdomen. Just kind of push on it. If you start feeling a real hard, rigid feeling in one of those quadrants, then they've probably got some kind of internal bleeding going on. You want to be able to physically inspect it too. Not just if they've got their clothes on, you don't want to just be feeling okay, it's wet, but it's been raining. Hey, that's not blood under there. You want to, that's why medics cut clothes. If you see a lot of blood coming from an area on the body, get rid of the clothes. I mean, in that disaster environment, there's no shame in cutting somebody's clothes. Then you're going to want to check the pelvis. And what you'll do is you'll grab the pelvis when they're laying down and you'll just kind of rock it, kind of push in and rock. Now, if they've got a pelvic fracture or something like that, you're going to feel it give. And then move down the legs. As far as a leg injury goes, what do you think would be one of the ones that would be the most severe besides an amputation?
Like an arterial wound.
What about a femur fracture?
Like that too.
A mid-shaft femur fracture is very serious. The femur is the hardest bone in your body. And whenever that thing snaps, that means it went under a lot of force and a lot of pressure. Not only that, there are a lot of muscles and tendons that hold that thing, so when it breaks, it does this and the bone will do that. Instead of being here, when it breaks, it'll do that. A lot of blood can get lost in a femur fracture. Now, the only way that you can start to try to treat that is something that we can't do in here, but on the ambulance they have what they call a traction splint. And that's where it's a big old long thing, they strap it to the leg, they hook a cuff to the foot, and they start cranking on it, and it literally pulls the muscle and puts the leg back in its anatomically correct position. But if they've got that femur fracture, yeah, pretty gory, huh? Pretty messed up.
No, he's like smiling.
Yeah. I mean, and if you've ever seen a good one, then you know they are going to be in excruciating pain.
When you put the traction splint on it, 9 times out of 10 it stops.
It does. When you put someone in traction who has that femur fracture, that pain will ease somewhat. But again, it's a specialized, funky-looking gizmo that they carry on the ambulance. And whenever you do that, there's some things that they have to continuously assess whenever they put somebody in traction splint. But that's a pretty serious thing because a lot of blood can get lost. And again, if you lose enough blood, what happens?
Shock.
Shock. You have to start looking at treating for shock. So, closed head, neck, and spinal injuries, we've talked about this. You want to be able to minimize the movement of the head and the back as much as possible. Now, it may mean that you're in an emergency environment, you have to do an emergency move. You may obviously see they've got head and neck trauma. But if the area is unsafe, and you're fixing to get hurt, and you're fixing to be even worse hurt, you got to just get them out of there. You got to move them the best way you can. I mean, in serious car wrecks, where people are critically injured, very seldom do you see the KED used anymore. Do y'all use a KED anymore?
We're gonna be trained on it, but everybody I've talked to said they've never used it.
And what that is, it's called a Kinder's extrication device. Rather than pick somebody up out of a car and lay them down on a board that's got a bad trauma, it's a deal that you put behind them while they're sitting in a vehicle, and you strap them into it, and then you can pull them out, lay them back, and then put them on a board. But they're very seldom used anymore. The reason why is because it's time consuming. When someone's seriously injured, we don't have that time to go through this process. The only time you'll see one actually used is whenever they're going to be on scene for a prolonged amount of time due to extrication, which means when they're pinned in to a vehicle and the ambulance can't transport them for an hour or better, they'll put them in a KED while the fire department's cutting around them. But we're not going to be able to, in that environment, you may just have to scoop them up and move them out of the bad area. And so just try to keep everything in line as best as you can if you suspect it. And then keep the head, stabilize the head. And when you're doing a move on somebody like this, it's going to be a group effort. You're going to have help. Now, you being the CERT member, it may mean that you have a whole bunch of civilians that are standing around not doing anything. You may have to say, hey, you four, come over here. You hold his head, keep it in line, don't make it go either way. This is where your training will facilitate others. You're going to have to be the ball caller here and telling other people who won't have a clue what's going on, what to do. And it may mean that you're the one that's also sitting up there saying, looking around going, okay, we got to move this person. All right, we got the table, we can put them on that as a board. And it may mean that you just can't strap them down. One person may just have to hold the head and other people carry the table and keep them in their inline position and get them to a treatment area. But if you've got your handy dandy bag with all your little toys in it, then yeah, you'll have all the stuff you need to do your job, right? All right. Treating burns. You want to look when someone is a burn victim. A lot of things are going on just other than them being burned. Because if a burn is bad enough, there will be shock. There will be respiratory distress. There will be a whole bunch of other things start to happen if a person is burned bad enough. But talking about superficial burns, if you have, we'll talk about full thickness burns, partial full burns, which first, second, third degree burns. Cool the area. Don't use ice, but try to keep that area cool. Don't use mama's old remedy for butter.
Nope.
Don't put butter on it.
Seals it in, cooks it.
That's bad. Now, I know that there's one person in this room that's had a visit to the burn center. It's that little girl back there in the corner. For those of y'all who don't know how they treat a burn at the burn center at Children's Hospital, they scrape it.
Oh, yeah.
And then the next day, they scrape it again. So imagine you slather somebody up with butter, and it just seals in the freshness and cooks it, and now they've got to scrape butter out of your leg or your body for the next week. It's pretty and nasty, horrific experience. So, keep it cool. You can put water on it, but don't put ice cold water on it. Cover it with a sterile cloth. They used to make these burn cloths that were kind of a wet cloth, like a wet blanket kind of thing. Don't use those. They've come back out and said, no, that's no good. Use a dry, sterile cloth to cover the burns with. Factors that are going to determine the burn severity a little bit. The temperature of the burning agent, obviously. How hot was it? If it was really hot, you're going to get really burned. The period of time that they were exposed to it. You know, that's the reason why most of the time whenever you accidentally touch something, you just get a small little blister because you weren't exposed to it that long. But if a person got knocked unconscious and then something burns them, it may be a pretty nasty burn that they didn't know was occurring. The area of the body affected. Now, there's a matrix, and EMTs have to learn it more in depth. But once a person gets a certain amount of second-degree burn on a certain amount of their body, and it covers a certain amount of the body in a particular area, they'll rule it worse than what it looks like. Like if they may have a superficial burn, it may be some pretty significant burns, but it's only like around a first-degree burn, and it's covering 75% of their face. They may upgrade that a little bit just for the severity of what got burned inside during the inhalation process. The size of the burn, and then the depth of the burn. So let's talk about the depths of the burn a little bit. Superficial, that's your epidermis, that's the top section. That's the one most time we get. Anytime we touch a hot stove or, you know, your buddy burns you with a cigarette lighter, that's what it is. All right. I tell you what, let's go ahead and take a quick break. It's 10 minutes past the hour. Let's take a quick break and then we'll come back and be back at 10 o'clock. We talked about the 10th of June. Would everybody be able to take a lunch break that day for a little while?
What's the day of the week?
It's Friday.
Who's buying?
And for how long?
30
I'm scheduled
30
test.
minutes, no problem. Longer than an hour, it might get iffy.
I'll just
No,
schedule a test.
we're gonna do like a little luncheon type thing. Yeah, June the 10th.
It would have to be in front, like at 11.
I just wanted to
Yeah.
Yeah.
Okay. So everybody would be good with that?
I can make it work.
Okay, cool. Now, real quick. And I won't give you your minute. I'll give you your minute. We ain't starting yet.
He said 10 minutes.
Yeah, I'm gonna give you your minute.
All I want to know is the governor and all our senators safe while you're over here?
Oh, yeah.
Okay. You're not leaving them exposed?
No.
Okay, that's all I
He
know.
has his cardboard cut out.
So, okay.
They're finishing up the last day of session this morning, so there won't be anybody there tomorrow. It'll be
So
like
is
a
the
ghost
time
town.
on June 10th gonna be a different time of day? Or still like
They
9
said
to 11
luncheon.
and
Yeah, well,
then afterwards?
11:30 good with everybody?
Yeah.
11:30, June the 10th.
Yes, sir.
Where?
Oh, sorry.
That email will come.
Not to be marked, that's yet to be determined.
It may wind up being right back in this room. But we'll let you know exactly when and where.
Here's my concern, is like, we're not gonna have all of these bags and all of this stuff. So what are you gonna do without the red and yellow? Just write it on paper and stick it to them?
If you have to. We're gonna get triage tags. If we ain't already got them, we're gonna get them.
Staple gun.
Yeah.
Fasten that.
And then you can learn how to, treat a partial wound.
We gotta see if they respond to pain tolerance. Pain, same.
Stimuli. There you go.
Okay. So, thank you very much. So superficial, we talked about that epidermis. The partial thickness, that's the dermis and the epidermis. A little bit more, you're gonna feel that one a little bit longer. I'll tell the story, like I said, my little one back there, she was playing, slid with her foot into a deal of coals, hot coals. Only exposed for maybe 5 to 10 seconds, tops. But nonetheless, she had a partial thickness burn on the top of her foot. And it still required a trip to the burn center, and they had to scrape it, care for it, all that kind of stuff. Again, exposure wasn't very long, but the heat source, coals are very hot, didn't take but just real quick. Then a full thickness burn, subcutaneous layer and all the layers above. This is when it burns to the bone. I mean, this is when the epidermis and the dermis are ash. It's not going to be the gray look. It's going to be the black charred look. Okay? It's going to be ugly. It's going to smell. If you've never smelled burning human flesh, it's not a smell you'll forget. And these are the ones that they may not even really feel this burn. It won't be that painful to them. Reason why is because all the nerves in that area have just been burned. When treating a burn, cool the skin or clothing if they're still hot. Oh, and let's put the disclaimer. If they're still on fire, put them out. Okay. All right. Cover the burn loosely with dry, sterile dressings. Keep the air out. That'll reduce the pain, and that'll also prevent infection. One of the greatest things burn victims have to endure in their recovery process is infection. When someone has a lot of burns over a large area of their body, they're very susceptible over time to infection. So, I mean, we know how it is sometimes whenever you get a scab on your arm and it gets picked or whatever, and you wind up getting it a little bit infected. Imagine an open sore covering the majority of your body and trying to keep infection out of it. And infection kills a lot of burn victims. Elevate the burn extremity if you can. Some things not to do: don't use ice. Don't use ice. Don't apply antiseptics, ointments. You know, that burn spray that's supposed to take the sting out. Don't use that stuff. Because again, whenever if it's a bad enough burn, now Solarcaine for sunburns, things like the aloe, yeah, I mean, we're going to use that kind of stuff. We're talking about for a burn of a traumatic nature. We don't want to put anything on that that's going to seal it in there, and they're just going to have to scrape it out anyway.
But you can use it for a superficial burn.
Yeah, absolutely. Superficial burns, yeah, use what you want on that. We're talking about when you have a large area of the body or a significant burn that is, second to third degree. Remove shreds of tissue, break blisters, or remove adhered particles of clothing. If they have something in the burn, like say, for whatever reason, they were wearing a nice polyester shirt that melted to the arm, don't just take that shirt and rip it out of there. Cut around it as best you can and leave it there. Okay? If they've got big old pussy blisters coming up, and chemical burns, you'll see that with chemical burns, they'll blister up real bad. Don't go popping them things. Because again, out here in the disaster environment, we don't know what kind of bacteria is floating around, and now you're getting it all off in there. They're going to do that a certain way at the hospital to try to keep infection control measures down. So try not to do that if you can. Chemical burns. Now they put the disclaimer, remove the cause of the burn. If it's burning, take that part out. Affected clothing and jewelry. If they get covered in something that's burning them, and it's all over the clothes and whatever, you gotta strip them down. Make them get it off. If it's a dry irritant, brush it. That don't mean you take your hand and start brushing it. That means that you try to, if you have to, get a broom. I mean, once you get them down, you try to brush it. And I'll tell you what'll work really well, a dry sponge. You know, it's not really that abrasive. Most sponges are kind of soft. You can just kind of lightly brush it. Don't wet it. You don't want to wet it because you may have a chemical reaction if that particular dry chemical reacts with water. But just kind of brush it off as best as you can. Brush it away from the eyes and you, which means you don't want to brush it down on somebody because it's going to go straight down and then all over you. You want to get to the side, brush it away from you and them. They say once you get done brushing the excess off, you can flush it with cool running water. But when you do that, you want to flush it. You don't want to just apply water. You want to flush them with water as much as you can, as quick as you can. Because if it is something that reacts to water, you want to get it all off as quick as you can and let it react to water on the ground, not on their body. Apply cool wet compress to relieve any pain. And this again is chemical burn. This isn't for dry burns. Cover the wound loosely with dry, sterile, or clean dressing. And then treat for shock if appropriate. Again, we start talking about burns. They're really susceptible to shock and infection and all kinds of stuff. Burns are a bad deal. Inhalation. People can, in the process of being burned, they can receive inhalation burns too. You'll see this a lot for people that have been exposed to structure fires. Or you can see firefighters in a wildland environment if they're not properly outfitted. What winds up happening is whenever the air inside of a particular area gets so hot, when they inhale, it's going to burn all the way into the lungs. And so, if all of a sudden loss of consciousness, they take a big deep breath air in. If you're in that situation and somebody breathes in suck in a big old thing of air and they drop, too hot. Evidence of respiratory distress or upper airway obstruction. If all of a sudden they're gasping, they just come out of this environment. Now they're gasping for air, they can't get any air. They may be swelling. There may be a little bit of light burning or blisters around their mouth, soot around the mouth and nose, singed facial hair. If I know he wears a beard all the time and they bring him to me and I'm treating him and now he don't have any facial hair, and everybody knows what burning hair smells like, it means something's too hot and close to his face and he may have inhalation burns. And then burns around the face or neck. So wound care. We talked about bleeding control in Unit 1, but wound care. Okay, you've got the bleeding control. We know how to do that. Now, you are left with this big old open hole or opening in the body. We want to clean it and apply a dressing and a bandage. You want to clean it by irrigating with clean room temperature water. Versus treating a burn, you want to put cool water on it. We want to put room temperature water on a burn. They say never use hydrogen peroxide to clean a wound. Now, I do it. I don't know. I've done it. I'll probably continue to do it on small stuff. on a small superficial cut or something like that. It's not gonna hurt it to boil it out a little bit. But again, if somebody's got a big old open, no, you don't wanna start pouring hydrogen peroxide off in there. Irrigate it, don't scrub. You don't wanna scrub the wound. You just kinda wanna, if you see trash and debris and stuff in that wound, you just kinda wanna put enough in there to kinda let it flow out, run down. Don't flush it because you don't want a lot of water just pounding on it. You just want to lightly irrigate it. Apply the dressing in the bandage. Dressing applied directly to the wound. You want to put it directly over it. The dressing goes there. Then the bandage holds the dressing in place. People have a misconception about just put a bandage on it. Well, there's a bandage and a dressing. And you may wind up, a firefighter or something like that may throw you his bag and says, grab me a bandage out of there. Well, you may look at, oh, that's a dressing. Here you go. No, that's not what I asked for. There are two different things. You know, a Band-Aid is 2 in 1. So, know the difference. Rules of dressing. Again, if it's bleeding actively and we're still in the process of trying to manage the wound care aspect of it, this thing is still bleeding. We're going to want to keep consistently putting dressings over never pull them off. Never pull the dressings off once you've applied them. Now, it may be so severe that you have piled up, you still don't have this thing under control, and you've piled up dressings that thick. You can take some of those off, just leave about the first 3 layers of bandages or dressings that you put on that thing. Don't remove the initial one. And then, of course, we all know how to try to control bleeding, direct pressure elevation. If no active bleeding, remove bandage and dressing to flush the wound only, if it's not bleeding.
Will we have in our bags those, and I only know this because my husband, we had to go through a wound clinic for almost a year. Will we have those wet, those for like bad wounds, you know, because I like you to put that, keep it,
Mm-hmm.
we were always taught keep it dry, keep it wet. The moist, where you peel and stick and then do the gauze.
Now, here's the thing, your bag, if you choose to buy one that has the first aid kit in it, we're going to give you the basic supplies in your bag. Okay? You can customize your bag however you want to by putting whatever it is you think you would need to do the job.
Just like now, instead of hydrogen peroxide, which we didn't know until we went, we have that wound wash now to keep. Instead.
Another thing too, if you can get a hold of a bag of normal saline. A bag of normal saline is great to flush wounds. Yeah. And so then check for infection every 4 to 6 hours. They say that because in our environment, chances are we're not going to be on scene 4 to 6 hours treating the same person. But if you found yourself in your own home or your own community where you're stuck there for that long due to an issue, and you may have to keep looking, you know, family member, whatever. Infection. I think everybody at one time or another has had some form of infection, light or severe. Swelling around the wound site, discoloration, discharge from the wound, that's pus, ooze, whatever. Red striations from the wound site. Amputations. When somebody just gets the whole thing cut off, meat, bone, and all.
Giddy about this.
Believe it or not, they're not as bad as you would think. Just because the limb's cut off, don't mean it's just going to be bleeding everywhere. You know, it's not as freaky as you would think.
We're not gonna learn how to open up a bullet before the gunpowder on there.
Yeah. Again, we talked about Quick Clot the other day. They make a product called Quick Clot. If you needed to use that to try to treat the end of the amputation, you could use that. If the body part is found, I mean, and you know it's theirs. If there's if there's multiple amputations of other victims, don't hold them up and try to figure out this your arm, that's your leg. Just package it. Just package them all up.
Like Cinderella.
I mean, and if they're awake, if they're awake and they're alert and oriented, chances are they can tell you what happened, and they're gonna say, "That's it. That's mine." But package it and transport it with them. It's amazing now how they can reattach limbs that have been amputated. 30 years ago it was an unheard of practice to try to put an arm back on, or longer. Now they can do it pretty reasonably if they've got the body part. And not only that, if the body part has the ability, if it's been taken care of. Because how many of y'all heard of the golden hour? From the time someone gets injured and they're critically injured, they've generally got about 1 hour to get to definitive medical care, a hospital. That 1 hour goes for these amputations. They can generally reattach whatever it is if they get it there in time. Because that limb, that leg, that arm, that finger, whatever, without blood flow to it, the cells in the tissue are going to start to die. And the quicker they get there and they can get the blood back to it and get it flowing, they can save it. All right. Save the tissue, wrap it in clean material, place it in a plastic bag. Keep tissue parts cool but not directly on ice. That's why you see a lot of times they'll package it whenever they're going to transport, say, like an organ. They put it in a cooler and they pack it with dry ice. They'll have dry ice in that cooler, but then the packaging that surrounds the organ, it just kind of refrigerates it. It's not directly laying on a bag of ice in a cooler. So if you run into that situation, you may not have ice at your disposal, you may not have all that. Try to just wrap it up and keep it in a cool place. If being in a cool place means you have to put it in the shade, or you have to occasionally take a bottle of water and pour on it to keep it cool, do that. And then keep the severed part with the victim. Now again, if you've got multiple, if you've got multiple, and again, you may run into a situation where multiple injuries, multiple amputations, depending on the severity of the scene. If it was like a nasty bus wreck where it rolled and went down a ravine and did all kinds of wicked, crazy stuff, it may mean that you have more than one amputation of a particular limb. It's irregular, but it could happen. And you just want to make sure that you get the right body part with the right body. Impaled objects. You could very well see this in a tornadic environment. Someone that's a victim of a tornado, all kinds of flying debris. It may wind up they get something impaled in them. And you may have to be able to secure that. You want to immobilize whatever part it is. If it goes through the leg, immobilize the leg. If it goes through up here anywhere, you're going to want to immobilize everything right here. If it's in the eye, and that can happen, if, pencil into the eye, seen that. Ran a call in Little Rock. Yeah.
Do they still say if you have an injury to one eye, you cover both eyes?
Cover both.
So they don't move sympathetic?
Yep.
Okay.
Absolutely right. When that thing, everybody knows that whenever you move your eyes, both of them are going to go in that same direction. Well, if this one's got a stick stuck in it and it moves, it's going to be doing this. So whenever they have one in dealing with eye injuries, if they've got and that goes for any type of eye injury, period, and into where you have to flush the eye and you want to cover it, whatever, do the other one as well, just for the sympathetic process of it. But immobilize it. don't attempt to remove it.
How do you immobilize the leg?
Cover up.
I mean, I know you cover it, but how does that?
You'll tape. Use tape.
Right.
You'll tape it and secure it. And that's just like what you're going to do also. You're going to, if say you have a big old piece of 2x4 stuck in their shoulder. You know, in a tornado environment, that's what you may see. Secure it. It may mean that you secure the whole thing down with duct tape. But prevent that thing from going deeper or pulling out. Because you don't know what it's tore up on its way in. It may actually be stopping the blood from flowing. And you reach in there and pull it out, you just uncork the bottle. So, immobilize whatever is impaled and the body part. Wrap it. And then start to control the bleeding at the entrance. Clean and dress it. Just like you would another wound, it's just going to have whatever's stuck in there. So, any questions? Fractures, dislocations, sprains, and strains. Immobilize it in the joints above and below it, which means if you fractured your tibia and your fibia, you want to immobilize the joint at the knee and the ankle. You want to make it so that those can't move. Best thing you can do for a splint, or to use for splints, for fractures, stuff, use just a standard piece of board. That's what you may find on your disaster scene. You know, if you can find something to break off, now they'll show you in one of these deals nice little fancy cardboard splints that you can buy and all this kind of stuff. You don't need that stuff. Huh?
Tree branch.
A tree branch. If it's big enough, you can make a heck of a leg splint out of that and some duct tape.
Good enough for John Wayne, good enough for me.
You use what you have at your disposal. If you're uncertain about the injury, treat it as a fracture. If you think it might be broke, treat it like it's broke. I mean, even if it's dislocated, you don't know if it's fractured, treat it the same way. Difference between a closed and open fracture, that's pretty self-explanatory. If it's open in the skin and the bone is exposed, it's open. Closed fracture, it's going to be, yeah, it's broken, but you won't be able to see it's broken, really. Or unless you can see it, the bone pushing close to the skin, you may not know. Now, the one way, we were talking about femur fractures a while ago, the one way you're going to know that they've got a femur fracture, yeah, the legs are literally, one's going to be obviously shorter than the other. Because when those muscles retract from that one that's broken, yeah, it's going to be noticeably different in the length of the leg. And they're screaming in agony. Treating an open fracture, this is when the bone is sticking out of the body. Don't don't push the bone back into the arm. That's no good. You don't want to irrigate this wound either. You don't want to start pouring water on it. Because you've got bone marrow, you've got all kinds of stuff in there that when it's broken, you don't want to just be pouring junk into that wound. Not only that bone sticking out, there's a hole in there, and there's a whole lot of stuff down in that arm. You don't want to pour a whole bunch of water in there that somehow they're going to have to get out, or it's going to have to hurt to absorb. Long process of recovery. Cover the wound with sterile dressing. Splint it without disturbing the actual wound. Which means if the bone is broke up here in the arm and it's sticking out right here, splint it down here. Don't try to splint it up here and wrap it all up. Go on the other side of the arm and try to keep away from the wound. You want to be able to, again, you want to immobilize it, but you don't want to disturb it other than just trying to manage it. Place a moist dressing over the bone end. Again, we're not going to flush it with water, we're not going to irrigate it, but we are going to put a moist dressing over the bone just so the bone don't dry out. Displaced and non-displaced fractures. The non-displaced, it's where the bone remains aligned in its anatomically correct position. This is mainly like a stress fracture. When you see a stress fracture, it doesn't completely break, but it stays right where it needs to be. And then, of course, a displaced fracture was whenever it breaks and it offsets. That's the one whenever they show you your x-ray and you go, oh, that's it. Dislocations, injury to the ligaments around the joint, they can be severe enough that it permits separation of the bone from the normal position in the joint. Elderly folks, whenever they are really susceptible to having hip dislocations.
Does it mean prevent separation?
Yeah. So severe that it permits separation of bone from the normal position in the joint. The way to treat it, immobilize it, don't try to relocate it. You know, how many of you guys seen Lethal Weapon? You know, Mel Gibson always dislocates his shoulder and he just hits the wall and jams it back into place. No. No, we're not going to do that. If it's dislocated, we'll immobilize it. It's not a difficult task for a doctor to put one back into place, but nonetheless it needs to be done by a doctor. Reason why is because you go in there monkeying around and trying to put somebody's shoulder back into alignment or into socket. There's a lot of veins, there's a lot of stuff that's connected up there, and all of a sudden you put it back into place and it's where it needs to be, but now they can't feel their fingers and you can't feel a pulse in their hand. There's no blood flow. So let a doctor do that part. We're just going to immobilize it. And again, check the pulse motor sensation before and after splinting. Before you get ready to splint anything, any extremity, if it's the leg, check the pulse in their foot. Check their pedal pulse. You check that, make sure that they do have a good pulse in that extremity, or in their arm. If you're going to splint the arm, check it. And then, once you do the splinting and you get everything all wrapped up, check it again. And then continuously, ever so often, if you're treating this person, check it again. The reason why is because you may have gotten, or whoever splinted this injury may have put it on too tight. And if they have, they've cut off the circulation. And obviously, you don't want to turn a dislocation into a forced amputation whenever you've cut the blood supply off and it's sat for hours. So that's what you're going to assess before you actually splint anything. Check the pulse, and then after you splint it, check it again. And then just continue to monitor it if you're going to be on scene for a prolonged amount of time. And anytime you undertake any type of medical treatment, it's just always good to, whatever you're doing, check their pulse. And then after you get done doing what it is you're doing, check it again. Because if they've still got one, you're doing good. All right, signs of a sprain. Tenderness at the site, swelling and bruising, restricted or loss of use. Probably everybody in this room sprained an ankle at one time, or an elbow or something. And we know it hurts, but we'll live. What we do, we elevate it, put some ice on it, and we go on about our way. In the event it's bad enough where, you may look at it and suspect that it's broken. The way we're going to do that is, one of the best ways to splint a foot, duct tape and a pillow. Take a pillow, wrap it around the ankle, and duct tape it. It provides cushion, support, and it immobilizes that foot. And whenever you elevate it, they'll feel 100% better, even if it is broken. So we talked about splinting a little bit. Another thing that you can do, and you see right here, they kind of what they did, same principle with a foot to immobilize it. When you want to immobilize the neck, and say, one of the things that a disaster is correct to use is a pair of shoes. Put the sole of a shoe on each one side, strap it down, it'll keep everything in line. Towel rolls, if you have towels, you can roll those towels, put them around the neck and the head, do the same thing with them. You notice when they splinted this leg, they went above the knee right there, and then down there at the ankle whenever they immobilized above and below. support the injured area above and below. When you get ready to splint, somebody needs to put their hands on that body part and support it and hold it in its anatomically correct position. Or if it's not in its anatomically correct position, hold it where it's at to splint it like it is. Have them hold that. While they're holding that, you're the one that can maneuver the splint where it needs to go. It's really kind of hard when you're trying to put a splint on and the legs flopping here or there and they're screaming and all that. Somebody needs to be holding it. Get the splint in place. Again, check their pulse on the extremity that you're wanting to splint. Splint the injury in the position that you find it. One of the nastiest things I've ever seen, and it was a partial amputation. How many people have watched chuck wagon races or been to the chuck wagon races? Okay, there's a guy known as an outrider, and he's on a horse chasing and trying to get in front of this wagon. And we were at the state finals, and I was working on the ambulance, when an outrider got thrown from his horse. And when he landed, his leg planted in the dirt like a lawn dart. And whenever it did, it snapped his tib fib, and the sole of his foot was pointed back at him, looking at him. The only thing that was holding the bottom part from here down on was the meat and the ligaments of his leg. Now, it's folded back, and I'm looking at full exposure. I didn't turn the leg back around and put it in line. I splinted it with his leg literally folded up against the other part of his leg and wrapped it as is. Yeah, we gave him morphine and flew him out of there. And he's probably still walking with a cane today. But nonetheless, when you find something like that, you splint it how you find it. We know the leg is supposed to be straight out. We don't put it back the way it is. We just splint it how we find it. That's for a doctor or a surgeon to do. Don't try to realign the bones or the joints. Again, if you see that the bone's like this, don't go in there trying to put them back together. Fill the voids and stabilize. What that means is whenever you say you have a splint, you put that splint on, and it's a full leg splint, well, this part of the leg is bigger than the lower part of the leg. Well, the splint may be wide enough for this, and when it gets down, there's going to be voids on each side of the lower part of the leg. Stuff those with something if you can. It'll prevent that leg from moving one side to another. Of course, we talked about above and below immobilizing the injury. And then again, after you have splinted this thing, check their pulse. Check their pulse. In a leg injury, you may see an EMT or a medic, they'll put a little X on their foot where they check their pulse and the time. That way they can go right back to that area, put their fingers on the X, and they know how long it's been since the last time they checked it, or when they applied the splint. And that kind of helps them gauge, okay, yeah, we still got good blood flow. Another thing they'll do is, we talk about capillary refill, they'll pinch that toe, see how quick that blood flows back to the toe. Nasal injuries, blunt force, trauma to the nose, skull fractures. Non-trauma conditions can be sinus infections, high blood pressure, and bleeding disorders. How many of you guys have seen, nobody got injured, but they may have high blood pressure and all of a sudden, boom, they get a nosebleed and you can't stop it. Again, that's, no matter how you're losing blood, and you've only got so much. And if it's coming out of the nose and enough of it comes out of the nose, it's still a very critical thing to deal with. All right, large loss from nosebleeds can lead to shock. We all know that if shock's left untreated, it can kill you. Actual blood loss may not be evident because the victim will swallow a lot of it. If they've got a lot of blood gushing, what you're seeing, there's a lot more that's going down their throat. And they're going to start gagging and hacking and all that kind of nasty stuff. Control it. Everybody here knows how to control a nosebleed. Lean forward. Squeeze right up there. Put pressure. Now, why do we not put the head back? Yeah. All that nasty stuff goes down the throat. And for people that, enough of it, if you've ever had a bad nosebleed where you got some of that throat or that blood down your throat, it makes you sick to your stomach. All right. And you want to ensure that you don't compromise their airway. So, let me ask a quick question. How would dealing with this? Say you got somebody that's suspected they've got a neck injury. Okay? And you've got them immobilized, but they're gushing blood from their nose.
Tilt their whole body.
On the side.
Very good. You tilt their body to one side and let that blood flow while you try to manage that. You try to put that direct pressure on there. Very good. All right. And then keep the victim calm. Try to keep them as calm as possible. Some people freak out at the sight of blood. And especially if it's theirs and there's a lot of it, somebody just really may lose their marbles on you. So try to keep them calm. All right, we're going to cover this real quick. Again, we talked about this at the beginning. It may mean dealing with cold and heat-related injuries. You may wind up that they're not suffering from it at the time of the disaster, but after being on scene for a prolonged amount of time, they may start suffering from it. You know, one year we had a tornado in November. Okay? Pretty cool outside in the middle of the night when your house is blown away and you just escaped in your pajamas. And now you're waiting on family 5 hours away to come get you. You got to start watching for hypothermia. So, and frostbite occurs whenever extreme cold shuts down the flow of the extremities and starts killing the tissues. Symptoms of hypothermia, the average body temperature is what? All right. When it starts dropping below 95, you're going to start suffering from hypothermia. Redness or blueness in the skin, numbness and shivering, slurred speech, unpredictable behavior, and listlessness, that's lethargic. If they just start getting very lethargic, then you're going to need to start paying attention in those cold conditions. How are we going to treat it? If they're wet, take those wet clothes off, wrap them in a blanket, actually get them out of the weather, obviously. Provide them something to drink if they're conscious, and they can drink it and eat on their own. Help them get something warm in their system, coffee, whatever. Don't try to massage the warm body part. Just kind of let them naturally warm. Place unconscious victim in a recovery position. Everybody know what the recovery position is? On their side. Place the victim in a warm bath. Now, I'll say this, we'll talk about heat-related injuries in a minute. You can put them in a warm bath and let them naturally slowly warm, but do not take somebody that is overheated and stick them in a cold bath. You will send them into shock by doing that. They'll seize on you. So, it's good to warm them up, but not to cool them down. It's bad. Symptoms of frostbite: skin discoloration, burning, tingling, partial or complete numbness. If they've been exposed and it's cold enough that they've been exposed to frostbite, it's bad. And chances are they're going to lose the extremity. Because if it's killed the cells and the tissues and all that stuff, they can't get that back. They may lose their toes and things like that first. If it's significant enough, then they'll lose the foot. They try to save what they can, but lots of times gangrene sets in, infection, and they have to remove it in order to save the person's life. Frostbite treatment: immerse the area in warm water, not hot water. Don't allow it to refreeze once you've unthawed it. Don't attempt to massage it, and then wrap it in a dry, sterile dressing, just as you would, say, a burn. Heat-related injuries. 3 types: heat cramps, heat exhaustion, heat stroke, which we're probably in Arkansas going to experience or have seen someone experience all 3. Heat cramps, everybody's probably had heat cramps at one time or another that's been out working in the yard in the summer too long. Heat exhaustion occurs when exercising or working in extreme heat results in loss of body fluids, and then a full-blown heat stroke whenever the cooling system of the body says, I've had it, I'm done. And it just completely shuts down. And then that's whenever brain damage and all kinds of nasty stuff starts whenever the body gets too hot. Heat exhaustion, cold, moist, pale or flushed skin, heavy sweating, headache, nausea, vomiting, dizziness. I mean, this is whenever they're just really overworked. You see a guy, you know, a military guy going through basic training at Pendleton in the middle of July. Yeah, he's heaving, he's throwing up, he's sweating, he's hot. But he's going to be alive, he can hydrate, he can cool down, going about his way. He's going to be exhausted and dizzy and everything, survivable. Heat stroke, they're going to just feel straight hot to the touch. Their skin's going to be red. They're going to quit sweating. Their body's going to get so hot that they have quit sweating. The cooling system, the sweating cooling system has shut down and stopped. They're going to start changing, their mental status is going to change. They're going to start talking out of their head. They're not going to know what planet they're on. And then rapid, weak pulse, shallow breathing. They're going to start gasping for air. Again, the biggest 2 things to look for, the red and dry skin and the lack of perspiration anywhere. Treatment for this, remove from the heat area to a cool environment, cool the body slowly. Again, don't put them in a cold bath because you'll hurt them. Have the victim drink water slowly if they can. If they've got the mental status to do so, have them sip water. No food or drink if the victim is experiencing vomiting, cramping, or in and out of consciousness. Another thing that you can do, everybody knows for the most part where the main blood lines are. You know, you've got a main brachial artery through here, you've got a femoral down here. One of the things you can do, those blood highways carry blood all around the body. If you will go to one of those pressure points and put a cool ice pack in their groin, around their neck, under their arms, as that blood passes through those areas, it will slowly start to cool as it travels around the body. That's one of the things that you can do to help facilitate starting to cool somebody down quicker. If you want to go to those areas, you can do that. Alright, bites and stings. How many in here don't know how to get a stinger out? I think everybody knows how to do that. Take a credit card, rake it across there, and it'll pop out. Wash it. Some people, you can put ice on it. They make the little things now where you can break it and rub it on there and it takes the sting out of it. Pretty superficial stuff until you get into anaphylaxis. And that's when someone is highly, deathly allergic to bee or wasp stings. And when they get stung, they can die. The main thing you want to do, check the airway. Make sure that they can still breathe. Keep them calm. Just because they're stung don't mean they're dead. It means we just got to handle a short problem. Remove the constricted clothing, any jewelry, anything like that around the neck, anywhere, get it off. If they have an EpiPen and they are conscious and alert enough for you to assist them in using it, then do so. If they are unconscious, don't push that EpiPen, even if it's in their purse or whatever. Let EMS do that. But if they're conscious and they're alert and you can assist them, and they say, yeah, will you help me, give it to me? Yes, I will help you. And then watch for signs of shock and then treat. Anaphylactic shock can kill somebody real quick. That's probably when you see the biggest scares involving shock, most of the time it's anaphylaxis. Somebody's had an allergic reaction to something and it shuts their airway down. And what it does is it swells up, it swells the airway closed. All right, so unit summary, public health concerns related to sanitation, hygiene, water purification, organization of disaster medical operations, establishing the treatment areas, conducting head to toe assessments, and then treating wounds, fractures, sprains, and other common injuries. Does anybody have any questions? Sorry that this was the long block, trying to get through it. At the end of the day, back to what we've been saying all along. If for some reason you see something that needs to be undertaken but you don't feel comfortable doing it, by all means don't do it. Document what needs to be done and try to get somebody that's trained to get it done. All right? Well, thanks, guys. We'll see y'all same bat time, same bat channel.
A different bat room.
Yeah.